top of the hour. So good evening and welcome to the ASJ Journal Club. I'm Dr. Denise Sarhadi. I'm your moderator for this evening, and I'm joined by my co-moderator, Dr. Miriam Zamani, and of course, a lady who needs no introduction, Phaedra Kress. Tonight, we will be discussing a relatively hot topic, which is likely in the forefront of our and our patients' minds when it comes to breast augmentation. Our article for tonight is entitled Subpectoral versus Subfascial Cosmetic Breast Augmentation. Are we ready to settle? And is published in our current March 2026 issue. Presenting tonight is the senior author of the study, Dr. Kiya Movassaghi. Dr. Movassaghi is a board-certified plastic surgeon based in Eugene, Oregon, and is widely recognized for his expertise in aesthetic breast surgery. He served as president of the Aesthetic Society in 2024, and he is actively involved in education and training for plastic surgeons. Our invited discussants tonight are Dr. Stephen Sigalove, Dr. Troy Pittman, and Dr. Jerry Chittister. Dr. Sigalove is a board-certified plastic surgeon based in Scottsdale, Arizona. He's an early adopter of pre-pectoral breast reconstruction. He's a KOL for Establishment Labs, in addition to his numerous society and journal contributions. Dr. Pittman is a board-certified plastic surgeon with practices in both Washington, D.C. and New York City. He is sought after for his specific interest and expertise in complex revisional breast surgery. He's also actively involved in training Georgetown residents and Meath fellows. Dr. Chitty is unfortunately stuck in the OR, but he is a board-certified plastic surgeon based in Utah who specializes in subfascial breast augmentations. He regularly teaches surgeons and speaks nationally on modern practice building, social media, and aesthetic surgery techniques. And I hope he can drop in today, but if he can't, at least we know he's here in spirit. So welcome, and thank you all so much for taking the time tonight and lending us your expertise. The format for this evening will consist of a presentation by Dr. Movassaghi, followed by discussion, and of course, ending with a Q&A from the audience. So please be sure to drop any questions you have during the course of the discussion in the chat box, and Dr. Zamani will pose them to our experts. As always, please keep an eye out for the poll questions. They'll pop up. You can answer them. Hopefully they won't distract you too much. Now, without further ado, I will pass the mic to Dr. Movassaghi.
Thank you, Dr. Sarhadi. Thank you, Dr. Zamani and Phaedra for inviting me to join the ASJ and share my recent publication. And also I want to thank your invited distinguished discussants for this presentation. So do you see my screen?
Mm-hmm.
Perfect. So again, what we're going to discuss tonight is the paper that my group recently published in ASJ titled Subpectoral versus Subfascial Breast Augmentation, and Are We Ready to Settle? And the reason for that title was that there has been a lot of back and forth conversation, this pocket versus that pocket, but to this date, till this publication, there was no data comparing submuscular to subfascial. And that's why this data is kind of timely, because maybe it will answer some question or raise some points for discussion. As Denise said, I was just the president of the Aesthetic Society a year ago, and these are my disclosure, but I have no disclosure regarding this presentation. So pocket selection is a big part of when you communicate with your patients, and there has been a kind of a shift in the thought process, starting from subglandular pockets to subpectoral and now to subfascial augmentation, and also breast reconstruction. Actually, one of our invited guests tonight, Dr. Sigalove, was one of the pioneers popularizing pre-pectoral breast reconstruction. So what are the subpectoral pocket advantages? Well, traditionally, we talk about subpectoral augmentation, decreased visibility, because you have added coverage of the breast implant in the upper pole of the breast. And in my practice today, if I'm doing a subpectoral augmentation, that would be the only real advantage and indication for it. Cap-con rate, traditionally we always talk about, decreased cap-con rate, but if you go back and look at a lot of the data published on cap-con rate is mixed data. A lot of the data is duplicative, and also a lot of data came from the industry supported studies. So that data is being actually questioned. Oncological surveillance, there's no question that the mammograms are, in general, more sensitive if you don't have an implant. And with the implant, you have to modify the images. But also in the prepectoral pocket, you may lose some sensitivity with the mammograms. But with the onset of uh, the three-dimensional mammograms and also ultrasound, a lot of these problems are solved. Now, there are a lot of disadvantages with the subpectoral augmentation. Chronic pain, loss of strength when you cut the, I'm going to share some data on that from the orthopedic literature, but when you cut the muscle, origin of the muscle, by definition, you're going to weaken that muscle. Animation deformity that everybody's familiar with, malposition and double bubble deformity due to the piston effect, which I'm going to show you some example of, and water deformity if you have significant breast parenchyma that falls over the implant and causes waterfall deformity. This is a recent publication in the orthopedic literature that they looked at these women with and without breast implant in the subpectoral pocket. And interestingly, they found that there was clinical significance of subpectoral patients having difficulty with the shoulder strength and stability. And in fact, if you follow your patients long term, you start noticing that there is an internal rotation of the shoulder because the muscle shortens and it starts pulling on that shoulder. And that, as a result, causes a lot of compromise. And a lot of these women cannot do push-ups. In fact, I presented this data more recently in a conference, and a very prominent breast surgeon said women don't need pec muscle, which is to me is shocking because this is there for a reason and is one of the two most important muscle of your upper body core between latissimus and pec that defines your posture in the upper body. Here's what the piston effect is. Essentially, what's happening is the contraction of the muscle because the muscle covers part of the implant. It pushes this implant out, so it predisposes the patients to getting what's called lateral malposition. That's in that photograph with the caliper. That's how we measured every patient in the study. And as a matter of fact, I recommend everybody to look at their patients in a supine position because that's how you're going to diagnose the lateral malposition. And we measured that lateral malposition in our study. Anybody more than 1 centimeter movement, I consider that a lateral malposition. And the double bubble deformity, in part because of the piston effect and in part because of the origin of the muscle, you get that secondary deformity that's notable in the subpectoral pocket. Now, in contrast, the subfascial pocket, which was originally, I should give credit to Dr. Ruth Graf from Brazil, very prominent breast surgeon, who first introduced it in 2001, 2002. There are advantages. There is no loss of strength, so it's much more comfortable. It's a faster operation, much easier recovery for your patients, less pain. And also the difference between subfascial and subglandular, they're both prepectoral, but the difference is in the subfascial, you're preserving the Cooper's ligaments because, as you know, the Cooper's ligaments travel from the dermis through the parenchyma and land on the deep fascia, that pectoralis fascia. So if you're going under the subfascial pocket, by definition, you're preserving the Cooper's ligaments. And there's no piston effect again because there's no muscle involved. And also the other thing is you get improved cleavage. Why? Because you can now bring the medial border of the implants closer to each other to actually where the circummammary ligaments are, rather than be limited by the origin of the muscle. And in fact, as I'm going to show you in this paper, we showed that there was actually less capsule contracture in the subfascial, especially subfascial versus subglandular, because you have a layer of fascia that separates you from parenchyma, and therefore you have less biofilm contamination. Now, some of the disadvantages, you definitely will have more visibility in the upper pole because you don't have the muscle coverage. But now with the use of fat injection, I do a lot of composite augmentations for my patients. And even if the patient doesn't have fat donor site, we have off-the-shelf material available to us that we can use as a supplement or replacement for autologous fat injection. Now, there's also a question for the altered blood supply, especially when you're doing the subfascial, you divide all those perforates coming through the muscle. So if you're doing augmentation mastopexy, and you have to make sure that you know where your pedicles are, and you preserve your internal mammary, this second and third internal mammaries, because that's going to be the blood supply to your medullary complex. Now, for our study, we had almost the same number of breasts in both groups. So we looked at submuscular versus subfascial. This is one center and one surgeon, and it was a retrospective study of these patients. As you can see, we did the statistical analysis in terms of the demographics of the patients. The two groups are very similar in terms of their breakdown, their ages, and the implant size that we use. And we had a little bit longer follow-up with our submuscular augmentation. In fact, when we originally submitted the paper to ASJ, we had less of the follow-up on the subfascial. So we actually waited several more months. We went back, and a lot of the patients had not come back for follow-ups. They actually came back for their follow-ups. So we have much closer follow-up period, although still a little less than the submuscular. Now, this was interesting observation that we saw and when we did the statistical analysis. So you can see the CAPCON. And when I say CAPCON, I know a lot of the publications, especially the publications by the industry, because of the FDA requirements, they do not report CAPCON 2 as a CAPCON complications. Whereas in this study, we actually included that in our study. So anything in my practice from 2 to 4 is considered a CAPCON complication. So you can see the CAPCON rate in the submuscular was 5.2% versus 1.1% in the subfascial, with a statistical significance of 0.04. Lateral malposition makes sense. You have that piston effect that pushes this implant out. So 23% versus 8.7%. And somebody actually, when this got published, somebody they made a comment and said, "Oh my gosh, you have a 23% malposition." Well, guess what? We look at all of our patients in the supine position. So if you're not looking for it, you're not going to find it. So this is a very honest observation. I bet you that number is pretty equivalent. We did not use very large implants for our population. I'm going to show another data that's actually very telling in terms of the lateral malposition. But again, very statistically significant, higher rate of lateral malposition in the pocket. Now, these are patients with no texture implants. Everybody had a smooth implant, no mesh or any ADM was used. These were all primary augmentation. Again, double bubble deformity was statistically significant in the submuscular, where 3.6% versus 0% in the subfascial. Again, p-value of 0.02. And as you know, the treatment of double bubble is change the pocket from subpectoral to prepectoral, and the double bubble goes away. Other complications, they were very similar in terms of like infections, wound breakdown, any of those things. So there was nothing different between the two groups. The other thing interesting finding with this paper was that when we looked at the structural support of the breast, you know that the SFS of the breast, which has the two layers, anterior and posterior layers, it comes together and joins the deep fascia, the pectoralis fascia and the serratus fascia in the periphery of the breast, and they join and form what's called circummammary ligament. Now, circummammary ligament is strongest medially and inferiorly, what we call IMF, and is depicted in the red color, and is weakest in upper pole and laterally, where you get a lot of the malpositions depicted in the yellow color. And this is a paper that was published by Rankin 2018 PRS. The other one is the Cooper's ligaments that, again, goes from the dermis through the parenchyma and lands on deep fascia. And here is just showing, again, the circummammary ligament. This is an anatomy data from Motiva group that shared with me that shows the circummammary ligament where you see the pectoralis comes in. So that's why if you're doing an implant in the subfascial plane, you can put the implant more further medial than if it's in the submuscular, because the origin of the muscle prevents the implant from going more medial. But you can see laterally that ligament is very weak and almost not as existent, whereas medially and inferiorly is much stronger. So what was interesting in our data, we looked at both in the submuscular group and the subfascial within their own group. Where the camel's back broke was around 330 cc implants. So in both groups, any implant larger than 330 statistically had higher rate of malposition regardless of the pocket. And then when we looked at all the implants together, both submuscular and subfascial, we again found the same thing. That 330 cc is the magical. And this data has been published in the past, but again, we proved that our data is in line with the published data. Again, it's statistically significant more than 330. So for those of us So number one, my advice is do not use wide implants. And as with other techniques of implants that's coming out, maybe Dr. Pittman can comment, but we are familiar with some other techniques by other companies, is move the implant more medial and superior where you want the volume of distribution to be, and avoid lateral placement or inferior placement of the implant because our patient already has volume there. You don't need to go there. And number two, if you're going with the heavier implants, even the primary augmentation, especially with introduction of a lot of these GLP-1 patients, consider maybe as a prevention use of some of these mesh products that we have available or ADM to support your lateral pocket to avoid getting this complication. So on that note, my conclusion from this paper was that subfascial augmentation has less complications in a statistical fashion and preserves the function. And the composite augmentation allows for more patients to become a candidate for subfascial augmentation. And lastly, select narrower and smaller implants to avoid complications in the first place. On that note, I want to end the presentation and thank you again for this invitation. I'm happy to discuss and answer questions. Hopefully, we ready to settle this, but if not, hopefully we have some controversy that we keep fighting.
Thank you so much, Dr. Movassaghi. That was wonderful. Um, I'd like to pass it off to our discussants. Dr. Pittman, do you have any thoughts at this point on the findings of the article, the idea of smaller implants, smaller problems? Where what is your decision making in your practice in
Yeah.
relation to this?
So, the beauty of this paper, and I congratulate Dr. Movassaghi on publishing, a study that really shows that the dual plane, which has been touted as the end all be all in our dogmatic thinking in breast augmentation, is flawed. And one of the things that I think is really interesting from a historic perspective is that when you look at Tebbett's dual plane paper was published in 2001, Ruth Graf's subfascial paper was published in 2003. And what was going on in 2001 and 2003? We were in the middle of the moratorium on silicone implants. And so we were already, by 2001, we were already 5 years plus into the moratorium where we were desperately trying to find a way to cover um, saline implants. And so both of these techniques were about trying to find a way to not put a saline implant in the subglandular space. And so when we're talking about dual plane, particularly, we have to know historically where we were at that time.
So
That's
it sounds like
right.
sorry, Dr. Movassaghi.
No, 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 no. Go ahead, please.
So
Please.
it sounds like back in the day, it was the options of subpectoral versus subglandular for saline implants that have a bigger water hammer effect, have more rippling, less natural feel. And we found ourselves back in pre-pec subfascial with the newer implants, basically.
And really, when we talk about implant placement, we can even go further with a pre-fascial. I've had the privilege of being part of an anatomy group, and our paper has just been accepted and will be coming out in the coming months. This was a group with Manuel Chacon, Ruth Graf, Rob Ranke, myself, and some actual anatomists, PhD anatomists. And you actually see that in front of the pec fascia, there's a very, very stable pocket where your circummemory ligament lays over that, and there's a posterior lamella behind the breast. So you are separated in the prepectoral plane from the corpus mammae, from the gland tissue, because there are stacks of fibrofatty tissue. And we see this when you do a prepectoral dissection, you see this posterior lamella behind the breast. And so it's almost a third plane where we're now placing implants. So the implant is supported by the circummammary ligament. It's also separated from the corpus mammae, and it's in front of the pec fascia. And so you avoid some of the complications that are involved in putting the muscle right on the pec muscle itself, putting the implant right on the pec muscle itself.
Dr. Sigalove, what are your thoughts?
Yeah, I mean, I think, like Troy said, we've learned a lot about the anatomy in the last year or two, especially with the advent of some of these new devices. But I think in regards to your question, um, absolutely, from a historical standpoint, it was dual plane, dual plane, dual plane, saline implants, high incidence of CapCon with the traditional subglandular. And, that's because we never really appreciated the whole biofilm reasoning behind capsular contracture. And, the surgeries were fraught with infections and, capsular contracture rates, which were not reasonable. So naturally, we switched to a better dual plane position, which for years and years did beautifully. Um, in my own personal evolution of this topic, I was dual plane all the way, and finally, with our cancer reconstruction patients, we realized that we could be putting implants under these mastectomy skin flaps, assuming we had well perfused mastectomy flaps, which we did. Going on top of the muscle, supported with ADM or some other type of matrix, and these patients did beautifully. And a lot of those were with the textured implants. And I think it's important to kind of, from a historical standpoint, to remember that many of us used these macro textured devices.
Oops. Is he frozen for you guys too?
Yes, we lost him.
Get him back.
And so putting an implant, a smooth implant on top of the muscle was challenging, and support was a question. So a lot of what we knew from reconstruction, we kind of parlayed that to our cosmetic practices and started using more supportive
Dang.
really nice outcomes. So like for me personally, I really changed the entirety of my practice from a dual plane position to a prepectoral position, to the point where today I virtually do no dual plane surgeries other than revisions. I do an occasional primary dual plane augmentation, but in my practice, it simply is mostly from a historical standpoint.
So, what is your decision-making process for doing? It seems like you're doing all subfascial, and it seems like we're almost coming full circle and doing subglandular again, based on what Dr. Pittman's about to publish.
Not
Yeah,
subglandular.
it's not subglandular though.
But
It's
it's not pec fascia.
it's
No.
not under the
So
fascia. Troy will
if
tell you,
He'll
you
tell us.
see
the
in that,
expert.
if you see in that Ranke description,
Mhm.
he calls the posterior lamella the space between the posterior part of the corpus mammae, the breast gland itself. There's a
Mhm.
layer that Ranke at the time called the deep layer of the superficial fascia. So it is a distinct fascial layer. When we look at that histologically, it turns out it's almost like a French pastry where you have fascia fat, fascia fat, fascia fat in this little what we call posterior lamella. That posterior lamella lays on the pec fascia, and that is somewhat of a potential space. It allows the pec to move freely under the pec fascia. It also is the thing that allows the breast to move and glide on the chest wall in a natural way.
Mhm.
So when we create that space, we have named it the intralamellar plane. So it's not under the gland, it's not under the pec fascia. It's in front of pec fascia, behind the deep layer of the superficial fascia. And so you create that pocket. Cooper's ligaments actually attach from that posterior lamella to the pec fascia. And that's what creates the circummemory ligament. So I would submit that if you're under the pec fascia, you're actually outside of Cooper's ligaments, because Cooper's ligaments stop on the pec fascia.
Yep.
Mhm. Dr. Movassaghi, what are your thoughts on that?
No, I think Detroit just exactly right. So the Cooper's bite, the advantage of the soft fascia actually go under this pec fascia is you preserving the Cooper's ligaments. But Troy, in your study, so I'm very interested when you publish it, because I actually was talking to Manuel Chacon, and he told me about the study. So th is that posterior layer of the SFS that was in original Ranke paper? So that still exists. And then you in front of that or anterior to that, you have another layer called the lamella, posterior lamella of the breast. Is that correct?
In Ranke's paper, he actually calls the posterior lamella the layer that is made up of the posterior, the deep layer of the superficial fascia. The issue is when you look back, Matusik described this. There's actually a really great publication that talks about how this layer has been named 5 different things, which I think makes it so confusing. But when we look at all of the other parts, what we learned from Ted Lockwood, we have these same layers in the abdomen, pre and post scarpal. We have the same layers in the face. So there is, and it's embryologic, really. It's really where the ectoderm and the mesoderm meet. And so when we think about the breast as an ectodermal structure that invaginates in, the whole breast is all ectoderm. And it's not until you get down to that deep layer that the ectoderm meets the mesoderm. So if you really look embryologically, those tissue layers exist in the breast, they exist in the face, they exist in the abdomen, they exist in the thighs.
I think you just I think this kind of brings up a good point, Denise. And I think I want to hear anybody else has a comment, but I think it's emphasizing that, as plastic surgeons, we should always question what we do. And hopefully we can come up with data to back up our argument. Because one of the unfortunate things in aesthetic plastic surgery, especially, is we do things anecdotally. And as we know from science, the sum of the plural of the anecdote is not data. Just because one surgeon does it, the other surgeon does it, doesn't mean you have a data. So it's good to have data to back up of our arguments and then go back to the laboratory. And, these beautiful, I'm looking forward to seeing this paper by Dr. Pittman and his group, because I was just in Costa Rica and I got familiar with the study. And it's important to go back and question what we're doing. And, Ranke's original paper in 2018 kind of illustrated for a lot of the anatomy for us. And we with understanding the anatomy and the circummammary ligament, we understand that you don't want to use wide implants, you don't want to use big implants. And then with this new techniques and new way of thinking about breast augmentation, which actually I have incorporated in my practice now in the past couple of months, is volume of distribution. We talk about it, but now you put implants where your patient really wants in the upper part of the breast, not in the bottom, not into the armpit, but those areas, and you're going to cut back a lot of complications, but you're also going to improve your outcome. You're going to have happier patients. So I think I'm happy to have this conversation because again, it emphasizes the importance of data, anatomy to back up our, whatever we claim.
And I think Troy is spot on. It's learning the anatomy, kind of this new breast anatomy, so to speak, even though it's always been there, but it's now being described differently. I think it's going to change how a lot of people actually perform their primary augmentations, and it's really teaching us about respecting the natural tissues, not destroying everything, and not making a big hole and stuffing a bigger implant in. And it's really making a lot of sense using smaller devices, very small dissection in whatever way you want, and it's really being a game changer. And the goal, hopefully, is going to be longevity. And we've been doing these types of procedures now, for a while, and we're starting to get our longer term follow up. But I'm excited to see what happens, over 3 years and 5 years, and are they going to hold up the way our open procedures do? Should we be using some type of support on some of these cases? I do it still. I don't know that it has to be done on every case, but I still will use soft tissue support. I think it's still warranted. I'm not sure about that circummammary ligament not stretching over time, particularly with larger volume implants. So in my practice, with a little bit larger implants, even though I'm using this minimalistic technique, I'm still using some support for depending on the volume that I'm using. And just like Kiya said in his talk, which is excellent, by the way, Bigger implants are going to equal bigger problems. So I think we have to be very meticulous about the base widths that we're thinking, the volumes that we're thinking, and then also the soft tissue support if necessary.
And I think it's important for the folks to understand that if we can do the operation better, get better results with better understanding of the anatomy and have data to back it up, there is no reason to cut the pec muscle. The pec muscle, as I said, as the orthopedic literature shows, is there for a reason. It wasn't created to be cut. And we're doing a cosmetic operation. We're not salvaging a limb here. We're doing purely a cosmetic operation. So why are we sacrificing an important core muscle for the sake of just because that's how we've done it for many years? So we have to question the status quo.
And on that point, we are able to do above the muscle surgery routinely. I don't think I've cut a primary pec since 2017, to be honest. I've done it in revisions, but because we have better devices nowadays than the old school smooth saline implants that bounced around like a hockey puck with huge dissections, we know more about dissection and the anatomy, and having better devices is that have anti-inflammatory, antimicrobial properties, having the ability to use soft tissue support when you need it. All those things have given us the options of doing a lesser invasive surgery that, quite frankly, our athletic patients deserve. And to cut a pec muscle in a professional athlete is ludicrous. I would never do it in this day and age, knowing what we know now. So I think prepectoral, for a while, many people were poo-pooing putting implants over the muscle. Many people that popularized breast surgery are poo-pooing it. But to be honest, I think we're going to start showing some pretty impressive data regarding CapCon, regarding malposition, and all these things. And I think the tide will be turning. And I'm not saying don't do dual plane. I'm saying at least be open to not cutting the pec in the right patient.
Mm-hmm. So in terms of support for an implant in the pre-pec plane, do you routinely, Dr. Movassaghi, Dr. Pittman, do you routinely include Galaflex? It sounds like Dr. Sigalove does it on a case-by-case basis.
I would say it depends, as Steve said it beautifully, it depends on the situation. So as my data shows, if I have an implant higher than 350, I
You'll do
start in
it.
my head, okay, I need something, regardless of what I'm doing, which plane I'm using. That patient is already predisposed to malposition, number one. Number two, an ounce of prevention is much worth than a pound of treatment down the road. So, as Steve also said, patients are going to age. Gravity is not going anywhere. So even if you didn't violate the circummammary ligament, that ligament, just like in the face, those ligaments attenuate with time. And then also with this sort of a new era of GLP-1 patients, a lot of us are treating
I'm
these
getting
patients
bored,
with weight
Susan.
loss. Or we're seeing a lot of these patients that are already compromised when they come to see you. So when you see a massive weight loss patient, attenuated breast tissue, poor skin quality, you should decide that's a patient I'm going to prevent malposition and use some kind of a dissolvable mesh of your choice to avoid those.
Dr. Pittman, do you use Galaflex
Any-
routinely for subfascial in particular?
No. Oh,
Okay.
hold on one second. I think I got kicked out.
No, you're good, Troy.
Dr. Sigalove?
I was going to say, Denise, I wanted to clarify what you stated.
Oh, please.
I use P4HB or Tiger Mesh in every subfascial open
Right.
augmentation I do. I use it in every single one that I do. For the limited non-cutting newer technique that we're using now, I am using it in a case-by-case basis. But I for all my open subfascial augmentations, I'm using it in all my primaries, every single one,
Awesome.
and every revision I do as well.
Do your patients ever bulk at the extra expense or time? Not that it takes that much time, but the extra expense is not cheap material.
Yeah, so everyone, we're very transparent. Patients, we give prices over the phone, so there's no surprises. Everyone knows how much it's going to cost, and I have a long discussion regarding the patients, regarding why I use it. I talk about my whole reconstructive kind of history and how we evolved from using soft tissue support, and after that conversation, which is a pretty lengthy conversation, most of the patients are like, well, that makes a lot of sense. I definitely want it. it's like it's way easier and way cheaper to do it up front at the primary than to do it for a bottoming out case or a cap con case in the future. So I choose to do it proactively, and I chose to do this after my first couple subfascials when I was a lot younger, both bottomed out, and I said I'm never going to do this again. And also, my average implant size is somewhere between 425 to 450. So I'm using high volume implants, and I would never not support these, especially in, like Kiya said, more and more patients on GLPs, weight loss patients, thinned out patients, multi-paras patients. So I think it's really important, at least to have it out there. I think 10 years ago, nobody ever would have talked about using mesh in a primary augmentation.
Mhm.
Now it's almost like common to be talking about. At least we're having this conversation. People aren't looking at me like I have three heads. But that's the same thing that happened when we started talking about subfascial as well. And like everything else, it evolves and people start catching on. And I think you are already seeing more and more people using it for primaries, and I think
Mhm.
it's going to continue.
Dr. Pittman, so just to clarify, are your implants smaller and that's why you're not using mesh, or you just have kind of a different philosophy in terms of adding soft tissue support every single time?
So I don't use it routinely in primary augmentations.
Mhm.
I think that, just based on where I practice, I tend to see smaller women who
Mhm.
want either smaller implants, who aren't, coming in asking for 550 cc implants. But, I think that one of the things to recognize, I mean, I don't think that I don't think using mesh is bad. I just don't really feel the need to use it. Now, in a mastopexy augmentation on a weight loss patient who is going to have attenuated Cooper's ligaments, and I'm concerned about the longevity of that position, I don't think mesh is bad. I have no problem with it. It's just not something that I use as routinely probably as Steve, but we spend a lot of time together talking about this, and I think his average implant size is just larger than the patients that I see.
Got it. Um, and a word on revisions. How does your original plane affect your revision surgery? Do you find it to be easier? Is it harder? You guys have experience in all of the different planes. You've been
Yeah,
around the block, reconstruction.
I think, I mean, when someone has a dual plane malposition, fold malposition, capsular contracture, multi-recurrent capsular contracture, to me, there's nothing easier on the planet than doing a site change, capsulectomy, new implants on top of the muscle, fortified with soft tissue support, plus a mastopexy. Like that's like standard revision for me. And
Mhm.
and having a virgin pocket to dissect exactly hand and glove fit, being careful not to, injure any of the perforating vessels, et cetera, et cetera. I think it's really, it's very straightforward. Regarding the vascular supply of the prepectoral, there's been a lot of talk on podiums in the last 5 to 10 years by a lot of people who are big proponents of dual plane, who say that doing on top of the muscle surgery devascularizes the breast. And yes, they're right if you take out all the perforators medially and laterally. But a really interesting paper came out a few years ago that I think is worth mention. And I forget the specifics on it, but essentially, there's a steal effect when you perform prepectoral augmentation, and you actually get dilation of the lateral perforating rows of vessels, and so the blood supply is actually robust. So when dual plane people say that you should never do prepec, especially if you're going to do it with a mastopexy or revision, because you're going to have nipple necrosis, all these things, it simply is not true. The vascularity is absolutely better than it was before you started the surgery. And it is a beautiful MRA paper that's published. I can get it for people if they email me. But along those lines, again, like there's nothing like dissecting a fresh virgin prepectoral pocket, whether you're in that posterior lamella space, whether you're subfascial, you're prepectoral regardless. And to me, that's really nice. The challenge, the question really is, if you have a previous old subglandular patient,
Mhm.
and they have a capsular contracture, are you going to do the classic switch to dual plane, or are you going to do something a little bit different? And there, I think it takes a little bit of finesse. And I've been doing these kind of neo prepectoral pockets, keeping them above the pectoral muscle, pectoralis muscle, not going dual plane because of what Kiya mentioned with shoulder girdle weakness and hyperanimation deformities and, water hammer effect and, waterfall deformities, all those things that are classic for dual plane. The reason I don't do dual plane anymore, I've really liked keeping them above the muscle, but kind of doing this like neo pocket, as Pat Maxwell would describe when coining, the dual plane neo subpectoral. Now we can do neo prepectoral, and it works beautifully.
You're absolutely right, Steve. And I think as we're talking about the circummemory ligament and using narrower, more projecting implants when we want a bigger implant, it's important to remember all of the vessels and the lymphatics live in the circummemory ligament. And so, I worried more about bleeding in a dual plane than I ever do in front of the pec. Because if you're really respecting the circummemory ligament, it's always the lateral perforators are the ones that give you all the trouble. I think if I look back at any hematomas that I've gone back on in the last 5 years, the bleeding was always from the lateral side. And so when we're doing this dissection and we're being very thoughtful, not only are we keeping the blood supply, we're keeping a strong central mound if you're going to do a mastopexy or a revision mastopexy. And we're also preserving lymphatics. And so when we're talking about decreasing capsular contracture, decreasing biofilms, having those lymphatics in place are, that's going to be paramount in this plane.
The other thing about the blood supply is when you're doing the superior supermedial pedicles, the blood supply that's coming off the second and third intercostal, it actually goes higher and through the parenchyma, whereas the fourth intercostal, which is what we use, for instance, for a traditional inferior pedicle breast reduction, that comes as deeper and then goes into the breast. So they're different planes. So by going the subfascial, as long as you preserve your circummammary ligament, as Troy said, that's where the blood vessels are coming through. You don't cut those, your blood supply should be at no risk. And in terms of your revision surgery, even all my revisions, I would say I almost never go subpectoral. Even if it's a prepectoral augmentation, with for whatever reason they're coming in, I use what Steve mentioned, the neo pocket. Uh, if it's not too messy, or you may use some kind of a mesh. I use Dorosorb mesh, but I also sometimes use the P4HB to support my pocket laterally, but I do not go in the subpectoral. I actually gone away from subpectoral. We know from recon, your prepectoral reconstruction looks better. Now we know from the breast augmentation, it's just a better operation for your patient.
And to
Very
Troy,
nice.
to Troy's point, for those of people who are not familiar with kind of doing a prepectoral or subfascial dissection for a primary, not only is important from a blood flow standpoint, but also from an aesthetic result standpoint and long-term stability standpoint, you got to really be extremely conservative on your lateral dissection. Do not open everything up laterally, because you will have lateral malposition because there's nothing there unless you're like wrapping the implant or using some long mesh. So very, very important. If you're not familiar with it, don't overdo it laterally. Let the implant and the weight of the implant do that lateral dissection. They will look a little bit tight at first, but they will all round out beautifully over the next couple of weeks. But the biggest mistake that people do who are just starting the subfascial or pre-pack is to overdo the lateral dissection. You will be sorry, and you'll have lateral malposition.
It's the same thing that, even in breast reconstruction, where do we always get screwed by the breast surgeon? It's when the breast surgeon is taking the breast out and dissecting all the way to the anterior border of the latissimus. That's where we run into trouble. And those principles, the breast is the breast, and anatomy is anatomy. And so those principles are exactly the same.
Definitely.
So we're at 45 past the hour. We have a lot of questions in the chat box. So I'll pass it to Miriam so she can keep this conversation going.
Fantastic. Thank you so much. That's been such a fantastic discussion so far. So thank you to all our discussants. And, this introduction of the interlamellar space has definitely been very interesting. And we have a few questions that are specifically targeted at the anatomy discussions we've had so far. So, first is whether using an inframammary crease access changes how you get to your interlamellar potential fascia if you're trying to preserve the inferior circumallar ligaments.
So when you go through your fold incision, through the skin, the first thing you see is Scarpa's fascia of the breast, which is, I think that Neil Handel calls it Scarpa's fascia of the breast. And really what it is the inferior circummammary ligament that you're entering into. Once you go
Mhm.
into that space, you're looking at pec fascia. And so, regardless of what you're doing, what type of operation you're doing, staying on top of the pec fascia, the only place that you're violating the circummammary ligament inferiorly or the fold is where you're going in at your incision point. And so you can make your entire dissection in that prepectoral intralamellar plane. And then when you close, there's no need at that point to anchor the fold. You know, we were so taught with dual plane to take a big bite of perichondrium or do anything to really anchor that plane down. But because we're not violating the inferior circummammary ligament, we're not violating the fold, when you close that circummammary ligament inferiorly as part of your deep closure, you've locked that plane down.
And you're making such a small defect in that portion of the ligament that it doesn't matter. And in some of the cases that we're doing with the newer techniques, you're literally just like popping through. So there
Mhm.
really shouldn't be any significant malposition. Again, my worry is more a stretching of that ligament inferiorly over time. That's my personal worry. That we know, like
Mhm.
Kia said, I mean, everything stretches, and especially with all these weight loss medications. But Troy's right. You know, you go through a very finite point and then you fix it as you're closing, and so there shouldn't be any issues with the folds.
Now, I think
Okay, love.
there should be, and maybe I want to hear what Troy and then Steve also think, but I think if you're some of the newer technique that you're talking about, and you're using an instrument to dilate in the pocket and get that right lamellar layer that you're talking about, if you're not using the dissectors and the balloon to expand that space, can you do that without the devices? And if not, then do in that case, are you better off to do a true subfascial under the pec fascia with a cautery?
So the answer is yes, you can do that dissection in a conventional type way. And so before we had the minimally invasive tools, we were routinely going in, making that pocket, being respectful of the circummammary ligament. You know, I think one of the first people to really describe a more minimally invasive or less invasive was Alan Gabriel. And so Alan was actually doing a very minimal dissection, something that all of us would probably consider to be too tight, and then putting in a sizer and using the sizer to really bluntly expand that pocket. And so we learned from Alan that you could actually do that. The important thing is to be respectful of the ligament and not dissect out too laterally. When I do this open, I'm only dissecting laterally, almost to the lateral border of the areola. And you would put your finger in there and you would say, this is going to be a flat breast. But unfortunately, the implant always wins. And it will round out with time.
And don't forget, Kia, you're not the first part of that technique that Troy just described, and you can't forget about this part, even in an open case, is injecting tumescence. And when you inject the tumescence in an open case, you're getting hydrodissection to separate the plane. So
Mhm.
you're pushing the posterior lamella down onto the pec fascia, and the rest of the space just opens up with hydrodissection. So you've already started that. And this is how Alan does it. He uses tumescence in the open augs. It starts the dissection, and then he puts a sizer in, like Troy said, and that really, gets that anterior expansion, just like a similar to the way a balloon would do it. But the tumescence is that portion of the procedure, because that's how you really are creating that space initially. And when you see it on ultrasound, it blows you away how beautifully the planes separate, and you see exactly where that device is going to go directly under high resolution ultrasound.
Yeah, if there's any question about the anatomy, as Steve is saying, and it doesn't really matter what you're using to make the pocket, I would encourage anyone who is interested, if you use your ultrasound and you put your tumescent cannula in on top of the pec fascia, and just inject 50 cc's of local, you will see the posterior lamella separate. And you can clearly see on the ultrasound the corpus mammae, and you can see that bright fascia of the posterior lamella, which is a distinct entity from the pec fascia. And that opens up, it almost unzips because you're taking that potential space and you're expanding that space where your implant is going to live. And it doesn't matter whether you're going to do the dissection or not. Just take the ultrasound and watch that one time, and you will see that tumescent will expand, and the borders of the tumescent will only go to the circummammary ligament. Whereas if you put tumescent under the pec, it would just diffuse out. It would be down on the rectus fascia.
It really is like tissue expansion on the
Mm-hmm.
table. I mean, when you have your tumescence in, it looks like an implant. I mean, it's pretty remarkable.
It's very interesting. One question I have is this paper was really fantastic. Discussion has been really fantastic in terms of addressing anatomy and in terms of addressing, the potential pitfalls of, either technique. How do you go about counseling patients in terms of aesthetics of having an implant above the pec versus under the pec? Because, discount, like, let's think larger sizes, maybe more moderate to full versus or demi high, whatever we want to call it, where there is that little bit of difference between, the gradual slope of dual plane subpec versus a little bit more of an upper pole appearance, roundedness with being prepectoral. How do you counsel patients regarding aesthetics? Do you factor that in? Do you fat graph? What is the panel's approach to that from an aesthetic discussion perspective with your patients?
I mean, Miriam, first of all, I would argue that I can't tell the difference between my dual plane cases and my prepectoral cases unless I ask the patient to flex. So what you just said is honestly like very kind of antiquated thought, where people think that prepectoral subfascial looks fake and people think that dual plane looks natural. That's just not true. Realistically, they all look fantastic. Now, so I think it's important to talk to the patient. What are you looking for? I'm a big believer of inspo pics. I think inspo photos are absolutely critical. I have them on my screen in the OR when I'm doing their cases. I also use 3D imaging during the consultation, which I feel is a very good communication tool. It's not exact, but I think it's a very wonderful communication tool so that you and your patient really are on the same page regarding the different projections. And are you going to use a more teardroppy looking implant, or are you going to use a more rounded implant? The first question that I ask them is, do you want to look more on the natural side, or do you want to look more fake? And if they say more fake, they're going to get a round device, probably a full projection. If they say supernatural, ballerina breast, yoga breast, etc., they're probably going to get an implant with a lot less projection and probably going to get a more teardroppy shaping implant compared to a round. But I think you have to talk to the patients and ask them, what are they actually looking for? Because as plastic surgeons, we can give someone exactly what they're looking for. But if you're not on the same page during the consultation by using 3D imaging or inspo pics, when someone says, I want to look natural, that could mean a million different things. And so I clarify, what does natural mean to me? It's a little bit more of a tapered upper pole, little bit more projection in the mid to lower breast as opposed to round and high. And in Scottsdale, we got a lot of round and highs. Guess what? They're getting a full projection implant. It's probably going to be in the 500s, and it's going to be exactly what they want. And yes, there will be full soft tissue support in all of those cases.
So, Mariam, in terms of this, since in my practice, since this paradigm shift from submuscular to subfascial, I have never had any single patient when I have the converse. I always give the patient the two choices because a lot of patients come in with this notion in their mind that, oh, my friend has submuscular, we're going on the muscle. When I present the pros and cons and talk about the strength, I've never had a patient say, I want submuscular, despite everything you just told me. So that's number one. Number two, I mean, Steve alluded some of the points, so I don't need to repeat that. So in terms of what you choose, but when you talk about implant size, when you say I use a forehand, a lot of times patients say, well, my friend had a 400 cc implant. I said, when I show them on the 3D pictures, you already have, a 400-gram breast tissue at the bottom. Why would you need to add more to it? Where you're deficient is in the upper supermedial, super upper pole, where everybody wants. So to get, let's say, 300 or 200 gram of that or cc of that volume in the upper pole, why do I have to use a 400 cc implant, which most of it's going to go in the bottom anyway? So when you give that analogy, when you show a sizers and you give them, hey, this is 200 grams, this is what it feels like. This is what this new implant is. Even though it's a 200 cc implant, you actually get all that 200 in the upper pole with all this new take practice. And my patients are happier and I'm getting less complications.
That's really wonderful to hear. We have Dr. Holly Wall in the chat box with us, and I would like to invite her to join us for the discussion because I believe she has some perspectives on the shoulder girdle study.
Well,
Dr. Wall?
Dr.
hi.
Wall, how are you?
Sorry, there's a lot of reverb. I think that study, I keep seeing it in people's talks about why we should go subfascial, and it's honestly a silly study. There are 14 people that are subpec, and we have no idea what level, if it's truly subpec or dual plane. So I wouldn't make decisions on that. And I love Manuel Chacon. I think this is all very good to discuss, but subfascial versus post-lamellar, intralamellar are totally different. So these are all just things we need to discuss and we're learning, but please don't look at this study about shoulder girdle to decide that subpec is not okay. We still have no radiological studies that show any improvement in the subglandular or pre-pec plane. That's unfortunately all these studies are old, and so we do need something current to actually help us decide what is better for our patients when 1 in 8 women gets breast cancer. That's what I would say.
I think that's definitely is a very good point. Thank you, Dr. Wall, for, just as we were being, very critical of our own studies in plastic surgery, also paying attention to the quality of the studies in the orthopedic literature. And I think, again, Dr. Wall is highlighting what Dr. Movassaghi said earlier about, understanding the potential oncologic significance of going prepectoral with the imaging implications and knowing what imaging potentials there are currently available to your patients in your area, what your patients' specific predispositions are, and taking that into consideration, which I know is part of his decision making as well. Fantastic. We do have one more.
Our child keeps calling.
Oh, okay. We do have one more question that's more technique dependent, and perhaps some of our surgeons could address. What is your technique for fat grafting when you're placing your implants also in the prepectoral plane? Do you approach from what plane are you specifically injecting your fat in, and what's your approach? Are you doing it like an internal fat grafting approach from like the fascial perspective, or are you doing it externally through the skin?
I do mine externally. I don't try to go from internal because I don't find it as effective in my hands. I think the best plane is the plane that you're comfortable putting the fat in. But for me, using a very small Coleman cannula with a 16 gauge needle, I can put that through externally and you don't see those marks.
I do the same thing. I just do a little stab incision with a 16 gauge needle and through the periphery of the areola, and then from there just feather out to the edges wherever I feel like it's deficient or I want to camouflage the boundary of the implant or the sternum when if the patient is deficient. And as I said, if the patient doesn't have the fat for composite augmentation, then there's options for off the shelf now that becoming more and more popular and I've been using in some patients.
Yeah, so I don't do any primary fat grafting concurrently with augmentation. This hybrid augmentation, I'm not a believer in. If someone needs fat grafting secondarily, I will always do it typically 3 months later or beyond that. When we did our original series of 350 patients in the prepectoral reconstruction, we had no capsular contractures in 3 years. However, when we took this further, we looked at patients who then later went to get fat grafting. We saw several cases of capsular contracture following the fat grafting. So for me, it really kind of I thought to myself, do we really want to be doing another procedure where potentially biofilm can form, inflammation, et cetera? And so I've held off on this kind of hybrid for not wanting to introduce variables. Plus, you never really know where the rippling or wrinkling may or may not be until you do the procedure, the swelling goes away, and you sit the patient up, or they bend over in front of you, which is really the only time you're going to see the rippling and wrinkling for the most part. So I like to fat graft secondarily. I think it's safe. I think you potentially are saving a lot of money. I'm a little bit, I feel that some of this hybrid augmentation is a little bit of a marketing tool. People love to have the liposuction, and I don't know that it's absolutely necessary, especially with the higher quality implants and sixth generation gels that we're using nowadays that really have very, very little rippling in the first place. So I'm not convinced that this hybrid augmentation is a great idea. I think it's reasonable to at least talk about, but I choose to do it secondarily, and I think it's a little bit safer and cheaper.
One of the things that I will say, and I'm probably going to get not stoned, but stoned to death for saying this, is what's interesting is all three of us have done thousands of breast reconstructions. And so I think that any notion that we're not oncologically minded with placing these implants, I think is certainly false. And there is no data to show that putting the implant in front of the muscle, particularly as Kiya said in his presentation, in the world of 3D mammograms, they're so sophisticated. Also with ultrasound, if there's a part of the breast that's not completely visualized, there's no data to show that women are developing breast cancer underneath implants that are placed in front of the muscle. Quite frankly, most breast cancer, first of all, we've been putting deep flaps in front of the muscle for years, and we don't see everyone getting cancer recurrences underneath the flap. Now, yes, you're going to say the breast is gone in a mastectomy. So, duly noted. But breast cancers, for the most part, are most common interparenchymally and superficial. So there are not the majority of breast cancers are not on the pec fascia. And so also in this plane that we're talking about, particularly if you're tumescing a little bit, ultrasound guided, you see that plane totally developed. And so, yes, we don't have data to show that it's 100% radiologically safe, but we also don't have any data to show that it is radiologically unsafe.
Thank you so much. We are at the top of the hour. I want to thank Dr. Movassaghi, Dr. Pittman, Dr. Sigalove, Dr. Wall, everyone who joined us tonight. Thank you for your insight, for your expertise, for helping us better understand the decision-making process and the upsides and the trade-offs for where we put our implants.
So I want to thank Denise and the group, Mariam, Fedra, everybody, my colleagues, Steve, Troy, Dr. Wall, to joining tonight. I think The title of this paper was, "Are we ready to settle?" And I think we're not. That's the good thing is, I hope we're not, because I think this is just one paper with one set of data, which is very convincing, but it's not the answer. It's a retrospective study, any study has pitfalls. But it should bring to our attention that we need to start questioning the status quo. We should always question the status quo. Look at how our facelift results are getting better because we question the status quo. So the notion that we're doing it one way and it's working and why it should change, I think that's not the right way of thinking about it. Science is always looking for the truth, and the truth is a fluid concept. The science is not the truth, is looking for the truth. And this truth is going to keep changing. So I hope this paper kind of brings up a discussion among all of us that makes us, okay, have the opposing viewpoints. I said subfascial from Dr. Pittman. The data is going to come out maybe intralamellar or sublamellar. Dr. Wall is saying different kind. So it should bring us and stimulate us to have this kind of engage in these conversations and question the status quo and realize that we need more data to support our arguments. And on that note, thank you very much, everybody, for joining tonight.
Thank you.
Thank you.
Thank you,
Have a great
everyone.
night.
Have a good night.
Good night.